MS in General Surgery from Grand Medical College and JJ Group of Hospitals. He's currently working as a general surgeon at VN Desai Municipal General Hospital in Mumbai. He has over 10 publications in national and international journals. He enjoys teaching, whether it's teaching maths at an orphanage or as a volunteer, or teaching basic science research methodology workshops or doing surgery clinics. He loves teaching, which is why he's here with us. Thank you, Dr. Parth, for being with us today. If you could introduce us and tell us a few words, it would be great.
Good morning, everyone. It's so nice to see so many people waking up on a Sunday morning for a clinic. Thank you, Global Surgery Network, for inviting me over here. Nethra, you have already introduced me, so I don't have anything else to say. We can start with the clinic whenever you are ready.
Thank you. Tanishka will now share her screen. Are you here with us?
Yeah.
Yes. Hello, everyone. Good morning. I'm Tanishka.
Okay, before we start, I'd just like to introduce Tanishka. Tanishka Balodia is a fourth year medical student from Guangzhou Medical University, China, and she'll be presenting a case on peripheral vascular disease for us today.
All right.
Okay, as she already mentioned, I am Tanishka from Guangzhou Medical University, a fourth-year medical student. Today, I am here to give a case presentation on peripheral vascular disease, as you all know. So, should I start now?
Yeah, Tanishka, what we'll do is first you read the whole history. I'll not interrupt you in between. After the history is over, you give a provisional diagnosis. Then we'll come back to the ODP and everything. And after that you say same thing for the examination. First you say the whole examination, and then we'll discuss.
All right, sure. Should I start now?
Yeah.
Okay. So, as you all know, peripheral vascular disease is basically like narrowing or blocking of any artery which carries blood from the heart to that specific part. So, a 65-year-old male patient came to the OPD. He is a resident of Guangzhou. Occupation is laborer and Buddhist by religion, with the chief complaints of he was having pain in both his lower limbs since 7 months, and he also observed a blackening of lateral malleolus in his left little toe since past 7 days. The history of pain. The patient was apparently all right 7 months back when he started experiencing pain in his both lower limbs. The pain was insidious on onset. The pain was initially present on the calf region. The pain was severe and it was a cramping type of a pain. But the pain relieved when he rested for a few minutes without any radiation. He also noticed that his little left toe and lateral malleolus was blackened. He is a chronic smoker, 1 packet every day from last 30 years. He is also having hypertension since 10 years and is not well adherent to his medications. He was having negative history of diabetes, hypersensitivity, lung disease, carotid arterial disorder, or CVD. There was no history of cyclical color changes on exposure to cold, no pain in his buttocks or impotence, and no long-term intake of any drugs for migraines or any other causes. There was a negative history of any swelling or foul-smelling discharge from the list. No asthma, no surgeries in the past, no known allergies, and patient denies any addictions. He was having a family history. His father was a diabetic patient, whereas his mother was a hypertensive patient. When we did a general examination in adequate light and exposure with the consent of the patient, we found that the patient was conscious and cooperative, averagely built and well nourished, was having a normal decubitus, temperature of about 98 Fahrenheit. Heart rate was normal, 80 beats per minute in radial artery when taken in sitting position. Regular rhythm, adequate volume, normal force, tension and character, no apex first deficit. Respiratory rate found to be 15 breaths per minute. Blood pressure found to be 162 by 107 mm of H. There were no neck veins seen. SpO2 found to be 89%. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy. The inspection was done in a supine position. The opposite lower limb, like the opposite of the affected lower limb, was normal. In the affected lower,
Tanishka, can we go over the history once, Dr. Parth, or should we
Yeah.
continue with exam?
yeah, sure.
Let's just finish the examination once.
Okay.
Yeah.
Okay.
Yeah.
You can go over to the inspection slide, Tanishka.
Should I go with the inspection?
Yeah. Finish it off. We'll do everything together then. So then there's no.
Okay, sure. So on inspection, the inspection was done in a supine position. The opposite limb, the opposite of the affected lower limb was normal. In the affected lower limb, we inspected that there was a dry gangrene, which was seen affecting his little toe and left lateral malleolus with a clear line of demarcation. The nails were brittle, the skin was dry. As you can see in the image, the skin is dry, scaly, without any hair, and we can see ichthyosis up to just below the knee level. Burgess test is positive. You can also see the dilated reddened superficial veins. There was no muscle wasting and no inguinal swelling was noted. Should I continue with the palpation or should I go back with the history? Should I continue with the palpation?
Yeah, finish your whole case.
All right. So in palpation, there was a local decrease in temperature in bilateral lower limb, increased capillary refill time. We found in the patient the increased capillary refill time was more than 0.2 seconds when we examined for the palpation. So when the palpation, the capillary refill time was more than 0.2 seconds was found. In the peripheral pulses, bilateral dorsalis pedis, anterior tibial, posterior tibial, popliteal pulses were all absent, whereas bilateral femoral, radial, ulnar, brachioid, and axillary pulses were found to be normal. Tender veins were present, no sensation loss found except in the area of the ganglion, and inguinal lymph nodes were not palpable.
Okay, Tanishka. Yeah. So
Yes.
we'll start over it again. I just wanted to reach over here so that I could see the picture of the ulcer, which would help in the history again. So we'll start over. Come back to the first slide, please.
Okay.
So if we begin, what is the first line itself? What is the importance of age in a patient with PVD?
The age basically it helps to decide whether it's a Burgess disease or atherosclerosis.
How exactly?
If
What
it's more, yeah,
Buerger's
if it's
disease is more common in what age group?
um, less than 50 years of age.
Less than 45, less than 50. It's even a part of the criteria for Buerger's disease. But the age
Yes.
over here is 65. So are you
Yes.
considering Buerger's disease which is more likely in this patient? Should it be towards Buerger's or should it be towards atherosclerosis?
It should be towards atherosclerosis because in Buerger's disease, the patient should be non-diabetic, non-hypertensive as well. But here the patient is hypertensive as well.
Okay.
So we can, yeah.
See, just on the basis of age, we at this point we are in no position to say. However, I just want to point out that the age of 65 is not the current age. You should ask what was the age at onset. Whether is this is a chronic disease, right? So whether he
Yeah.
has this since when he was about 45, 50 years of age, or has it started right? So that will help us decide. So just on the basis of current age, you will not be able to tell. Okay. What is the
Sorry.
importance of occupation in a case of PVD?
I didn't. Okay. Occupation.
Importance of occupation, yeah.
Yeah, like if it's a coal factory worker or something, so he might having the lung hypersensitivity lung disease.
Okay.
This is how we can differentiate what occupation a patient.
No. Occupation with respect to PVD, a case of PVD, peripheral vascular disease. What is the importance of occupation in this case? Is occupation important?
In some diseases, the occupation is specific.
In a whole lot of diseases, but in case of peripheral vascular disease, do you know of any specific occupations which are at high risk of peripheral vascular disease? Have you heard of Raynaud's?
No, I didn't.
Raynaud's phenomena?
Yeah, Raynaud's phenomena.
So,
Yes.
in which
Okay.
occupations is it more likely to be seen?
The coal workers or the laborers, the
It
construction
is
workers.
not exactly. It is more common in people who are working with drilling machines. People who are working on the roadside with drills or constant vibrations are more prone to develop PVD. Also,
Alright.
when you see the occupation, you will also come to know a general idea of the socioeconomic status of the person. And Burgess disease or thromboangiitis obliterans is more common in which kind of socioeconomic strata compared to atherosclerosis versus Burgess, which is seen in higher class and which is seen in the lower class of the society.
Atherosclerosis can be seen in higher classes, whereas
When Burgess disease, like tobacco chewers, smokers, BD smokers,
yeah,
when you
lower
take the
class.
Indian example, it will be more common in the lower class. Any significance of religion? There's no importance of religion in this case. So even if you want to omit it, that's fine with me in a case of PVD. If you don't say religion, that's okay.
Okay.
Proceed. What is the chief complaint?
He was having pain in his both leg, lower limbs, in the calf region, specifically from
Since
7
7
months,
months and blackening of lateral malleolus
and left it from the past 7 days.
All right, this is the chief complaints. Now we go to the ODP. Describe the pain. Can you describe the pain that he was having? How did he describe the pain?
Yeah, he he was having while when he walked, it was a severe pain in the calf region. But when suppose he walks initially with certain distance and then he rests for a few minutes, the pain relieved. But then when he walked, the distance gradually decreased from the previous one.
Okay. What is, the first thing when you describe pain is, what are the 5 points when you describe pain? Have you heard of the mnemonic sitar? Do you have any mnemonic for pain? First is the type of site, intensity, type, aggravating
Type.
factors, and relieving factors. You
Yes.
told me 4, you did not tell me the type of pain. So what is the type of pain that a patient with PVD will have?
A cramping type of a
Cramping
pain.
pain. Correct.
Yeah.
So this patient has a cramping pain.
Yes.
Site is the calf.
Calf.
Intensity, you told me initially insidious onset, gradually progressing and aggravated on walking and relieved on rest. That is a type of pain in a vascular condition. That is why this pain is called what? What type of pain? This
Rest
condition is
pain.
no. There is no rest pain. This is called intermittent claudication, right?
Intermittent claudication. Yes. Intermittent.
How will you differentiate a pain of vascular claudication, that is intermittent claudication, with a pain of neurogenic claudication or a neurogenic pain, and compare that to a osteoarthritic type of pain?
Intermittent claudication, the pain arises while resting. Like if the patient is walking, he won't uh, feel the pain. The pain only be felt when he will rest after walking.
Go ahead, complete it, then I'll correct you. Neurogenic pain, vascular pain, and osteoarthritic pain.
And neurogenic pain is when when the patient walks, he simultaneously affects, like he suffers from the pain simultaneously when walking.
Does anyone from the audience want to reply the chat box? So Zeel says posture taking pain on the first step in neurogenic. No, the pain on taking the first step is osteoarthritic type of pain. And when you talk of neurogenic pain, the pain begins after taking a few steps. It takes a longer time to resolve as compared to the vascular pain. So I'll repeat it for the last time. A vascular pain, the pain begins. You said about rest pain. You are confusing
Yes.
between intermittent claudication and rest pain. Both of them are a continuum of a vascular kind of pain. So initially patient will have intermittent claudication, which will eventually progress to rest pain. Okay. So in intermittent claudication, the pain will begin after he walks a long distance, say 1 kilometer, 500 meters or so. And then after he rests for a few minutes, the pain will go away. That is vascular pain, which is because of peripheral vascular disease. That is a vasculogenic pain. The second, this is called claudication pain. The second is neurogenic pain. Neurogenic pain is also called pseudo-claudication, and it will start when the patient walks a few steps, not as much as kilometers or something, but a few steps, and he will need to take a longer rest for the pain to go away. And another important point that Zeel highlighted was about the posture. So neurogenic pain relieves or gets aggravated with specific postures. One of the example of neurogenic pain can be spinal canal stenosis. So it will be increase. The pain will increase when you are stooping down. And the third type of pain is the osteoarthritic type of pain, which happens when you take the first step. Okay. Yeah. So what is claudication distance?
Claudication distance, the distance when the patient started walking, the between and he when he suffered the pain.
Yeah. And what is the difference between functional claudication distance and absolute claudication distance? Functional matlab with respect to pain, and absolute means how much the distance he walked, which makes him stop. Suppose I start walking right now, and after walking about 500 meters, I get pain, but I'm still continuing to walk. And then I walk up to 800 meters. So my functional distance is the first part, which is 500 meters, and the absolute claudication distance for me will be 800 meters.
8 meters.
800
Alright.
meters. Got it?
Okay.
Do you know of any classification of independent claudication?
Classification as in?
Have you heard of Boyd's classification for vasculogenic pain?
No.
See, there are various classification systems for vasculogenic pain, or that is PVD. One of them is Boyd's, which is the most basic one, which is expected that you all should know at least the Boyd's classification. The other two are Rutherford and Fontaine's classification.
Yeah, the foreign Fontaine.
Oh, you know that?
Yes, I know that.
Can you tell it for all of us?
Yeah, the food Fontaine grading, like it started from the claudication part. It's four types of a stating. Like if it's a Fontaine 1 is asymptomatic basically, and Fontaine 2 is for the intermittent claudication. Fontaine 3 is for the rest pain, and Fontaine 4 is basically for the gangrene. It is the primary investigation for the staging.
Okay, correct. Yeah. So, and in Boyd's classification, it's on the similar lines. You might have read about it. See, Boyd's one is uh, uh, when the patient starts to walk and he develops pain, and he still continues to, and he develops intermittent claudication. In Boyd's 2, the patient develops pain, but even he bears the pain and he continues to walk. And in Boyd's 3, the pain forces the patient to take rest. That is Boyd's 1, 2, and 3. So in this case, your patient has progressed from what class of Boyd's to what class?
From Boyd 1 to 2.
1 to 2. Is is the pain severe enough that he has to take rest?
Yes, the pain is severe.
I'm not talking about rest pain, but the pain that forces him to rest.
You mean when we walk from the classification of 1 to 2, so the pain was severe or not?
What is your question?
I said yes.
Voids 1 is when the patient has pain while walking.
Yes.
Voids 2 is the pain is patient bears the pain and continues to walk. It does not force him to stop. And in voids 3, the pain will force the patient to stop.
Yeah.
So in your case, the patient has progressed from voids 1 to
Voids 1 to 3.
3. But you have not mentioned it in your ODP, correct?
Yes.
Uh, uh, another thing I want to just highlight is there is something called as rest pain, which is not a part of Boyd's classification. It is seen in Rutherford's and it is seen in Fontaine's classification. Okay?
Yes.
Yeah.
Yes.
Proceed. Start. Yeah. Start reading it.
Okay, so he was having a negative history of diabetes, hypersensitivity, lung disease, cardiovascular disease, coronary artery disease, carotid artery disease, and no history of cyclical color changes on exposure to cold. No pain in his buttocks or impotence, no long-term intake of any drugs for migraine, no low-grade fever, joint pain, rash, etc.
Cyclical changes in color is to rule out what? With exposure to cold? Is to rule out?
The gangrene.
No. Why did you ask for cyclical changes in color on exposure to cold? And what exact color changes were you asking about? And what disease you have in mind when you ask for this?
The disease is for the peripheral vascular disease. Ask for the color changes.
Which disease do you have in mind when you are asking about this?
Gangrene.
No, this is for Raynaud's phenomena.
Sorry.
This is for Raynaud's phenomena. Am I audible clearly? Raynaud's phenomena.
Yes. Okay, got that.
So what is Raynaud's phenomena? Yeah, correct. Devanshu.
Yes, sir.
In Raynaud's, have you heard of Raynaud's phenomena? Do you know about it, or shall I say?
Yeah, it's cyclical color changes exposure are for the Raynaud's phenomena, like from paler to cyanosis and then to red on severe cases, right? For the vasospasm.
Generally seen in
In
males
the
or females?
Generally males.
More common in females, young women.
More common in young females.
Young females, yeah. It is seen in females. It is a temporary contraction of the digital arteries. In that, the radial artery will still be normal, but only the digital arteries constrict, which will cause classical changes in the color, where if first there's constriction of the vasculature of the digital arteries. So what color will it be if the blood supply is gone? It will become white.
White, paler.
White, pale. And then the color progresses from white to
blue
because of cyanosis, because of the buildup of deoxyhemoglobin. And then eventually the episode subsides on its own after some time. So then what will happen after the vasoconstriction is gone and there's again vasodilation, then the color will change back to
red
because of hyperemia. And it is seen in response to cold or in response to strong emotional stimuli also. Or when you are doing some any vibratory stimuli, any instruments, any devices which are vibrating when you use, it can get precipitated. Or when you are exposure to cold, it is more common in winters because the temperature is cold. Or when you put your hands in cold water, again Raynaud's phenomena can become precipitated in such cases. Got it?
Yes.
Next, you asked about pain in the buttocks or impotence. This is for what would you like to rule out by this? This is for Leriche syndrome or Hemi-Leriche syndrome. Yeah. Zeal is again answering aortoiliac block, that is Leriche syndrome. what happens in that? The block is at the iliac artery level. So if the block is over there, then what will be the symptoms?
Like the blood supply won't go to that specific part. There would be a lack of blood, and the
Yeah. So if
pain.
the iliac arteries get blocked, then the pain will be in the buttocks and
Yes.
impotence, because again the blood blood vessels supplying the penis will be compromised. So again, patient will complain of impotence. Okay. Next is history of long-term intake of drugs for migraine. What exact drug do you have in mind for this?
For the migraines, right?
Yeah.
Analgesics, hypnotics.
Okay,
Sedative.
there are two questions in this. First is, what is the usual drug that we prescribe for migraine, and which specific drug of migraine can cause peripheral vascular disease? First question is very simple. What is the treatment for migraine headache? Initially, you will WHO pain ladder and all. Initially, you'll start with paracetamol, and then you will add a NSAID. Okay. Yeah. And the drugs, and in severe the newer drugs which are now used are triptans, sumatriptans and all. Right.
Yes.
Okay. Please open audience. Okay. Yeah. So again, Zeel has answered that question. The answer is ergot alkaloids. So if you begin with paracetamol, then you add NSAIDs. After NSAIDs, we can add triptans. And initially, when the triptans were not discovered, ergot alkaloids were used for the treatment of migraine. Because what is the pathology of migraine? There is vasodilatation in the cerebral vasculature, which causes headache. Correct. And ergot alkaloids cause vasoconstriction. So ergot alkaloids were previously used. Currently, no one uses ergot alkaloids as a first or second line also. So generally, right now, this cause is not higher up in the list. But just to complete the history or the negative history for etiology, we ask for history of intake of ergot alkaloids for the treatment of migraine. Okay. What is the significance of low-grade fever, joint pain, and rash?
Because fever is low fever is usually seen in the gangrene, a patient suffering from vascular disease. Joint pain is for the blockage of any artery if due to lack of blood supply to that part.
No. Anyone else in the audience? Importance of symptomatology of low-grade fever with joint pain and rash. See, when you are saying these things in one line, it means all of this this is a symptom complex. Just like you ask for pain in buttocks with impotence in the same line, in the same breath, it should go out. Just like you ask for TB, no history of evening rise of fever with weight loss with chronic cough. These three symptoms will go hand in hand, and they all attribute to one particular disease like TB. Correct. Similarly, when you ask for low-grade fever, joint pain, and rash, it will all point towards one particular disease. That is how we rule out one particular disease in negative history. Correct. So all these three have to refer to one thing, which is vasculitis.
Isn't it for atherosclerosis?
Atherosclerosis will not give fever and pain and joint pain and rash. Vasculitis will cause. Okay.
Okay.
Someone else has written rheumatic disease, Radha. So yeah, rheumatic disease is possible if you are especially asking about if you have a patient in the Indian context, which is a poor patient. Patient will have a history of rheumatic fever in the childhood, which will then progress to rheumatic heart disease. And then how will rheumatic heart disease lead to peripheral vascular disease? What is the connection? Rheumatic disease is also a good question in the negative history, but not higher up. But what is the relation? How can you link rheumatic disease with a PVD? Okay. A rheumatic heart disease will cause mitral regurgitation. All right.
Yeah.
And all these will predispose later to mitral regurgitation. Then constant thickening of the valves will cause mitral stenosis.
Stenosis.
Right? After mitral stenosis, what will happen to the atrium?
to the left atrium?
It will contract. The atrium will contract.
The atrium, there will be atrial fibrillations because of atrial enlargement, left atrial enlargement, and atrial fibrillation can result. It is very common in a case of rheumatic heart disease. Are you following? So what will happen if there is atrial fibrillation? Very good. Yeah. Both of you all are correct. Radha and Zeel and Radha. So atrial fibrillation will give rise to, if the heart is over here and the left atrium is over here, it is not contracting properly. It is enlarged. Normal atrium will contract, but because of rheumatic heart disease, the mitral valve will constrict. If the heart will constrict, the left atrium will enlarge. The left atrium will enlarge. It will not constrict properly. So it will flicker. That is atrial fibrillation. So blood will get accumulated over here. When the blood will get accumulated, it will result in formation of clots.
Clots.
And what will happen if the clots dislodge into the vasculature? Then where all can it go? It will cause embolism. Okay. So if the embolus dislodges and goes in the carotid, then what will I get? I will get a stroke.
Yes.
Either a transient ischemic attack or a stroke, ischemic stroke, one of the two, depending on the intensity. And if this clot goes into the peripheral circulation, then I will get a peripheral vascular disease, PVD, but which will be of an embolic cause. All right. And why did I say RHD, rheumatic heart disease, is not higher up in my differentials in this case? Because embolus will be sudden, correct? And your history, your patient's history is of 75, correct?
Yes.
So what we are dealing with is a thrombotic phenomena where the disease is inside the peripheral vasculature itself. And a rheumatic heart disease will give rise to a picture of more like a embolic phenomena, which will be sudden. The history of embolic phenomena is, you know how much? It is from in hours. Patient came with history of blackening of the toes or blackening of the foot with swelling of within 5 hours ago, 6 hours ago, 10 hours ago.
Yeah.
It is in hours. And here we are talking about months. So that is the difference between thrombotic phenomena, embolic phenomena, and that is how you will try to relate rheumatic heart disease with this. But I don't want to ask about this. Why did I not ask about rheumatic heart disease? Because our history is of 9 months old, no? So we don't want to ask about rheumatic heart disease. But we want to rule out vasculitis. But again, vasculitis is more common in females, and this is a male. That is one point against vasculitis. Okay. There are more few more negative history points that you could have asked, which you could again point to peripheral vascular disease. Can you name a few of them? What if the ophthalmic artery gets involved? What will be the symptoms? Yeah. What will be the symptoms?
Blurred vision.
Transient episodes of blindness.
Yeah.
Okay.
I think
what if the abdominal aorta is involved? What will be the complaints? It's called abdominal angina. What will you ask for if you want to rule out abdominal angina? Pain in the abdomen, which increases after eating food.
Abdominal pain, distress.
You should also ask for stroke, which you have. How do you ask for stroke? You asked about there's no negative history of diabetes, hypertensive lung disease, which I don't know. Why did you ask? You don't need to ask over here. It's not even hypersensitivity lung disease you asked for, which is not important, not common in India. Maybe common over there. You asked for coronary artery disease and cerebral vascular disease, right?
Yes.
Yeah. So the answer is TIA and focal neurological deficits. But how will you ask the patient? Suppose you are asking the patient in Hindi. How will you ask?
For the stroke.
Yeah. What is a common word for stroke? What our patients will use? Suppose I want to ask for stroke. तो मैं what will I ask the patient? आपको क्या कभी stroke हुआ था? मैं ऐसे पूछूंगा. Firstly, I'll ask. Yeah, weakness is one of the way to describe. But usually, if you are short on time, what you should know common Hindi equivalent words of the words, right? So, what is stroke called in Hindi? People will usually recognize कि इसको stroke हुआ था. That is called lakwa. LAKWS. So, first I will directly ask कि आपको कभी lakwa हुआ था क्या? If the patient is Hindi educated in Hindi but educated enough, then he will say, हाँ इसको lakwa हुआ था. ठीक है? If he still is not able to answer, then how will you ask for focal neurological deficits? When you are asking the exam, you will say, I will ask for a history of focal neurological deficits. But when you are asking to the patient, how will you ask? whether he had any sudden onset weakness in a particular half of the body, or whether there was any drooping of the angle of the mouth, or any weakness of the eyelids, slurred speech, correct, paralysis of the arms, weakness in the
Paralysis.
arms, any voice change suddenly. All right, that is how you'll ask for history of cerebral vascular disease or stroke. For history of coronary artery disease, you can just say any heart attack or chest pain, which was
Chest pain.
sudden excruciating chest pain. All right.
Yes.
Okay, that completes your history. And then you want to ask for negative history of complications. There is no history of swelling or discharge from the lesion. What are you afraid of when you ask this question?
Whether it's a wet gangrene or other any infections due to the discharge.
Okay, correct. So, can you tell me the difference between dry gangrene and wet gangrene?
Yeah. Like in dry gangrene, we do not see any discharge or any other infection. And there's a clear line border in the dry gangrene. And
What is that
Yeah.
clear line border called? A better word for that?
line of
Line of
demarcation.
What is the
Line.
etiology? Difference in etiology between dry gangrene and wet gangrene?
Geological difference.
Etiological. Dry gangrene is blockage of the arteries only.
Arteries and wet gangrene is arteries, and it could also be a block of veins, like
Veins.
venous blockage.
And dry gangrene is usually slowly progressing. Wet gangrene, the block in the artery can be,
Like it's
yeah, correct. Everyone is correct.
rapid.
In wet gangrene, the block will be,
Wet artery or venous block. It could be.
it will be artery or venous, or if it's arterial block, it has to be very sudden.
Yes.
Okay, that will cause wet gangrene. If there is a slow blockage in the arteries, then it will cause dry gangrene. And if it's a sudden arterial and venous blockage or sudden arterial blockage, it will cause wet gangrene.
It spreads through.
What is the importance of the sudden blockage?
Occlusion, arterial occlusion.
Yeah, sudden arterial occlusion will cause. Yes, correct. Zeal. Acute arterial occlusion, so no collaterals. Correct. Then what happens if there is a sudden arterial occlusion and there are no collaterals? So what will happen to the limb? How will that cause venous occlusion? Stasis of blood with enlargement of the swelling of the limbs, that will cause venous occlusion. Okay. So what is the treatment of which is the surgery of choice for dry gangrene of the toe?
And angioplasty, bypass, vascular bypass surgery.
No, if the patient has gangrene, dry gangrene, what will be the level of amputation that you will do? Open to everyone. If the patient has dry gangrene of the great toe, okay, at what level will you amputate the patient?
It could be iliofemoral. In the iliofemoral.
I am just talking about the great toe. So the block is somewhere in the toe, right? In the digital arteries, probably in the dorsalis pedis or in the arteries of the foot somewhere.
Foot.
Correct. So yeah. So Zeal is giving two answers: below knee and raise amputation if in toe. Yeah. Manu is saying ankle amputation. Anyone else? If the patient has dry gangrene of the great toe, where will you amputate the patient? At what level? This is a trick question, open for everyone. I'm waiting for a few more people to attempt this question. Below knee, only the affected toe is amputated. What is your answer, Tanishka? At what level will you amputate it?
Artoiliac.
Only the great toe is gangrenous. then at what level will you amputate the patient? Will you amputate the whole leg, whole lower limb? It's a trick question.
The saddest fact.
So listen to my question again. The question was, if there is dry gangrene of the great toe, where will you amputate? So the answer is, you should never amputate a dry gangrene. Dry gangrene patients are left as it is unless there is any wet gangrenous changes over a patient of dry gangrene. Unless there is infection, superadded infection on it, you should never touch a patient of dry gangrene, because you will leave him with an ulcer which will not heal on its own. It will become worse than it already is. All right? Yes, it will fall on itself. So that brings you to the question of, how will you take care of the patient with dry gangrene? What advice will you give? What will you do? Will you admit the patient? Just great toe is blackened, shriveled, mummified, cold, no sensations, no vascularity, totally black. All right, that is how I am describing the picture of a great toe dry gangrene, with a line of demarcation at the great toe itself. Line of demarcation is well formed. So now, how will you take care of this patient? What will you advise?
Some medications or lifestyle changes to the patient. Advice.
Yeah, all that will come as part of PVD, which we'll discuss later also. But just for the dry gangrene part, how will you manage that part? See, Devanshu, technically antibiotics are not needed because dry gangrene is sterile. It is because of the block at the arterial vasculature which has caused mummification and dry gangrene changes with the, by definition only, right, Devanshu? The wet gangrene affects, wet gangrene is because of the superadded infection. In dry gangrene, there is no infection. So, antibiotics will not be of any use unless there are any changes of erythema or inflammation or fever over that swelling, over that gangrenous change. So what will you do? How will you take good care of the gangrenous part? Dressing, yeah, correct. How will you do that, Z? Wear socks good enough. Basically, you have to take care so that a superadded infection does not happen. So what you should do is, if the patient is with you, you can take spirit, soak the gauze with spirit, and tell the patient to clean it with spirit every day. So even if there is any local infection, superficial infection gets taken care of. And apart from that, maintaining proper hygiene, cleaning the foot properly, wearing good shoes, socks, checking for the foot for any ulcers, infections. There should be not be any repeated trauma to the foot. Patient should not walk barefoot. These are the advices that you will give to the patient who has dry gangrene, and you just tell them, do not get operated anywhere. No need to go anywhere. You just counsel the patient properly that this will fall on itself. And if you attempt any surgery, then the results will not be good right now. All right. But you will also have to look continuously, keep the patient under check for any changes of wet gangrene. Okay.
Yes.
Yeah. So that is how you were asked for the negative history of complication, which is history of swelling or discharge from the lesion. Okay. You can proceed. Past history. Okay. Okay. Yeah. Coming back to addictions, your patient is a smoker, right?
Yes.
Okay. So you can also tell me about the pack years that he has consumed so far. You know the pack year concept?
Yes. We divide the cigarette packets used daily into for how many years he's been using that.
Okay. So suppose I say that I am smoking 10 cigarettes per day for 20 years. Then what is my pack year?
10 cigarettes? No. How many packets?
I don't know. You asked me how many cigarettes I.
How many packets of cigarettes? Like suppose one packet contains 20 cigarettes.
If suppose that is the answer, one packet contains 20 cigarettes. In India, you can get a smaller packet also, but the defined criteria for one pack in this formula is 20 cigarettes. All right.
Yes.
So
Yes.
you may, what if I'm not consuming even one full pack a day? I'm saying 4-5 cigarettes per day. Then you have to divide that by 20. So if I say
Yes.
5 cigarettes per day, 5 divided by 20.
Yes.
Okay. You might not usually see people who are smoking full packets every day. You might generally see someone who is just smoking 3 to 4 cigarettes a day. That is more common than someone who is smoking 2-3 packets per day. Okay. So if I say 5 cigarettes per day, then 5 divided by 20 multiplied by the number of years.
Yes. Yes.
Okay. So that will be 5 pack years. 5 divided by 20 multiplied by 20. So 5 pack years. So is this significant? If I have 5 pack years, when does my risk increase after how many pack years? Risk for coronary vascular disease, risk for peripheral vascular disease, risk for COPD, risk for lung cancer, everything is different.
Yes. For peripheral vascular disease, I think it should be 40 years, more than 40 years.
40 pack years. 40
pack years. Pack years, yes.
And risk for COPD increases after how many pack years?
80.
No, less than that. 20.
Less than.
At 20 pack years for COPD, 40 pack years for PVD. Okay.
Okay.
Do you know of any other concept other than pack years? Have you heard of smoking index?
Smoking index, yes. Where
What is the formula?
Number of cigarettes per into for how many years?
Correct. And what is the significance level for PVD in this case?
For smoking
300.
index.
Correct. Correct. Yeah. Good Z. Okay. So yeah, you could have mentioned it again also. I wouldn't have mind. Along with the pack year calculation you can give. Suppose the patient is alcoholic. Then how will you describe?
How?
Take any fake example and give. Suppose the patient is taking. Suppose I am taking 2 beers every day for the last 20 years.
The quantity, like suppose one small or one small pet, the quantity into how many years?
Then will you also tell the brand because all the alcohols have different concentrations, no? So will you say I'm taking beer or I'm taking whiskey every day? Will you tell that?
Yes.
Yes. Is it needed?
The brand name is yes.
Then you will also say what is the strength. You will have to say so many things to describe exactly how much alcohol I'm taking. Like for Desi or branded. Okay, branded. Then you can say if the patient is taking Desi alcohol, then you can say patient is taking country made liquor for the past 20 years. Then that's the end of it. But suppose I'm saying I'm taking 180 ml of whiskey every day. Okay. That also I'm telling you XYZ brand, XYZ, for which you know a set amount of alcohol is there. I'm showing you the bottle. This is the brand of bottle that I'm taking 180 ml every day. How will you convert that in your history? How will you present that case?
Like I will mention.
Suppose my friend is taking 180 ml of wine every day. I'm taking 180 ml of whiskey every day, and another friend is taking 180 ml of beer every day. And who is at more risk? And how much is it? How will you quantify? How will you differentiate? How will you tell the examiner how much alcohol am I taking? Will you just say patient is a chronic alcoholic and that's it? Suppose the patient is whiskey is at more risk. Why? Ounces is the quantity. It does not depend on the ounces. I'm saying 180 ml for each of us. I don't know how much time we have. I think the session is still 12:30 or 1 usually, or there's no fixed time. Yeah, percentage and concentration of alcohol. Yeah.
Yeah, there is no fixed time. You can take it for as long as you want.
Okay. So if you all are tired, let me know. We can speed up things a bit. Otherwise, if you are want a more of a interactive session, then we'll continue at this slower pace. Because treatment and a lot of things are left. Pulses are left. If at this pace, if we go, it will easily be 1 o'clock. So if you're fine with this pace, then let me know. Otherwise, we can speed up a bit. Okay. Yeah. So how will you differentiate and how will you determine how much alcohol? there's something called as units of alcohol. Okay, and every alcohol will have the percentage or concentration of alcohol written. For example, beer is at 4 to 5%. The light beers, the strong beer is at 8%. Whiskey is at 14-15%. Wine is at 14%. Whiskey is at 20, 30, 40%. Absolute is at 40 to 50% of alcohol, absolute vodka. So you have to take that percentage of alcohol. That percentage is by as weight by volume. Do you recall chemistry? 5% weight by volume. How much that is? That is, if I say beer, okay. So for beer it is 4 percentage weight by volume. So 4 grams in 100 ml.
200 ml of water.
That is the definition of 4 percentage of alcohol of beer. Suppose I am taking wine, then 12 to 14%, depending on the which type of wine you are saying. It will be all be written on the label. Okay. So then you multiply that. Suppose I am taking 500 ml of beer, which is Kingfisher Light. So 4 percentage. So 4 grams divided by 100 ml. That is 4 percentage of alcohol. Multiply by 500 ml. How much that comes to?
4 divided by 100 into 5, right?
4 divided by 100 into 500. 0 cut, 4 5s are 20. Okay. Okay. So that comes to 20 grams of alcohol every day. Okay. Now in that 20 grams, we say in terms of units of alcohol. That comes to 20 grams of alcohol. And if I'm not wrong, 5 grams is 1 unit. It's given in Kundu. I'll check it by the end and I'll tell you. If someone remembers, can you just confirm whether it's 5 grams is 1 unit or 4 grams is 1 unit of alcohol? So if I say 20 grams, then I'm taking 4 units of alcohol every day. Okay. Alcohol is alcohol, C2H5OH. But the flavors concentrations will be different. But at the end, you have to convert that into units of alcohol and say. So patient is taking 20 divided by 5. That is 4 units of alcohol every day. Okay. Or you can say in grams if you want, but units is better. All right. Can we proceed? And the significant level is 80 grams of alcohol for females and 160 grams of alcohol for males in 1 week. That is the significant level for this thing. For alcoholic liver disease. 8 grams. Okay. All right. So I stand to be corrected. 8 grams forms 1 unit of alcohol. So 20 divided by 8, somewhere around 2.5 units of alcohol I'm taking every day. Okay. And 180 grams is the limit for week for significant alcoholic disease. Proceed. Next slide. Yeah. Family history: father is diabetic, mother is hypertensive. Okay. No, not much to say. Yeah. General examination. Start.
So the examination was start. The patient found to be conscious and cooperative, averagely built and well nourished.
Patient was a male, right?
Yes.
So what one more point would you like to add over here? In the presence of
a male attendant.
What would you use over there? In the presence of
a male attendee.
No, there's a specific word that you have to use. The examination findings, there are some proformas to it, so you cannot change some words. It has to be as it is. No attendee. There's a better word for it. Audience. Audience. In the presence of a chaperone.
Okay. Yes.
Okay. So
yes.
I would begin my examination as I would say I like to say that is my way of presenting. You can say in the passive tone also. The patient, the examination also. Or you can say I examined the patient in a well lit, well ventilated room, or you can say adequate light. That is also okay. With adequate exposure, that is also okay. But if you are presenting a case and you want to tell the examiner that you know more, then you can describe how much exposure. So then patient was with adequate exposure below below thighs, or how much, what did you examine? If you don't know, then you can say adequate exposure. Suppose if you're presenting a case of breast. So then you will say patient was exposed above the waist, completely above the waist you have to expose. You cannot just leave a part of the upper top and see. All right. So that has to be complete exposure. And for every examination, there is a set pattern. So for a breast case, you will say patient was exposed above the waist. For the lower limb examination, you will say completely of the lower limb or below the knees. Then I examined the patient in a well lit, well ventilated room with adequate exposure below the waist with due consent in the presence of a male chaperone. That should be one breath. Okay. And you should never fail this. So patient was conscious, cooperative. That's all right. And suppose if the case is something else, suppose if you're presenting a case of a lump in abdomen or some other patient where a patient is septic, then you might also want to add whether it's conscious or not, or whether it's oriented to time, place, and person or not. In this case, it may not be significant, but for some other patients, you may tell whether the or a thyroid case, hypothyroidism, where it will affect your orientation and all. So you will say conscious, cooperative, well oriented to time, place, and person. And anyway, in a long case, it is a good habit to stick to the performer. Okay. Patient was averagely built and well nourished. I hope you know the difference between built and nourishment. What is the difference? Built and nourished.
Averagely built is means the skeleton.
Yes,
The body structure, the skeletal framework of that
Correct.
patient. Nourishment is like the mass, the BMI of the patient.
Correct. In what always can you check for the nourishment of a patient?
Cancer patients, to check.
No, in what ways, what clinical examinations, what
Okay.
measurements will you do to check for the nourishment of the patient?
We pinch the skin to check for the mass.
Weight, height, BMI, people are saying that's okay. What else? Weight, height, and BMI. That is one thing. What
Yeah.
else can you check for the nourishment?
Triceps muscles or biceps, interscapular muscles.
Skin fold thickness.
Yeah.
Skin fold thickness. What else? Vanchika is correct. If you want to look for anemia, what will you see? That is also part of nourishment, all right? Nourishment is not only fat and thin, it will be all the signs of malnutrition. So when I say how will you check for nourishment, you have to start with body parameters and then you have to go to separate nutrients and then you have to say for everything. So it will come off, it will include all the signs of malnutrition, all the signs of vitamin deficiencies, all the signs of mineral deficiencies, everything. Suppose the patient is a 3-year-old child. What else can you check for nourishment? What else can you do?
Protein levels or vitamins levels.
For a patient, for a 6 months to 5-year-old child, we can do mid-arm circumference. Okay, to check for the nourishment of the patient. It's only applicable for pediatric age group. So BMI, mid-arm circumference, triceps fold thickness. For muscle wasting, you will check for girth. Suppose if you want to check for wasting of the thigh muscles, you will take a specific bony landmark. Suppose 15 centimeters above the tibial tubercle, 10 centimeters below the tibial tubercle for the legs. Then you have to compare that to both the sides. Girth of the biceps, all that. Then you will check for anemia. So for iron deficiency, we'll check for anemia in the lower palpebral conjunctiva. You will look for signs of malnutrition like kwashiorkor or marasmus. You will look for pot belly, loss of hair, easy pluckability of the hair, loss of appetite. These are all symptoms, but I'm now asking for signs. For a vitamin deficiency for rickets, what will you check for?
For vitamin
D deficiency.
The gum problems or the white rashes on skin, white spots, nails on nails. If the patient is having hair loss.
Go vitamin wise, okay, and then you will complete the whole answer. All the minerals and all the vitamins. If suppose you're talking about vitamin A, it's mainly based on the companies that is night blindness, but you can also see what are the signs of vitamin A deficiency. There is a mnemonic for that. Bitot spots are seen in xerophthalmia. You will see, but bitot spots you will see for vitamin A deficiency. Vitamin B deficiency, B1 thiamine. For thiamine, what will you see? Niacin deficiency, B1. Vitamin B, bleeding of gums.
Bleeding of gums.
Yeah. For niacin, what will you see? Dermatitis. What are the 4 Ds of niacin deficiency? 4 Ds of 3 Ds of niacin deficiency. Audience.
This.
Very good. Very good. All are correct. Can you read the chat box, Tanishka? Dermatitis, diarrhea,
Dermatitis,
dementia,
diarrhea, dementia.
and the 4th D is death. If you want. That is the 4 Ds of niacin deficiency. That is vitamin B, vitamin C, joint pains and all that.
Joint.
Cheilitis and all will be seen. Vitamin E, nothing much. Vitamin D, yeah, partake very important. I forgot about that. What about vitamin D deficiency? For the pediatric age group, you will have rickets, and for the adults, you will have
Yes.
rickets in children and what in adults for vitamin D deficiency?
Osteomalacia.
Yes,
Osteomalacia.
not osteoporosis. Osteoporosis and
Osteomalacia.
osteomalacia are different. Correct.
Osteomalacia.
Malaysia. So all the signs of vitamin D deficiency. Then comes to other signs of mineral deficiency, zinc deficiency, selenium, all the important things you can see. All that completes the answer of nourishment. Examiners like to ask about nourishment. Okay, so prepare this answer well. Then comes the next part is decubitus. What is a decubitus?
It's a position of a body when lying in a bed.
Okay. What decubitus will the what posture will the patient assume in a case of PVD when the pain where the pain will reduce?
At, at an angle of 30 degrees.
Which angle? Angle of no pain will reduce. I said if the patient is sitting, yeah, by the side
The
holding
side
his
of the board. Foot.
yeah,
Holding his foot.
he will either be holding his foot or he will be dangling his head in the air by the side of the bed. Why?
Yes.
Why that?
By hanging his leg will give the pain relief because the blood circulation in the patient is in supine position, so it will reduce to the lymph when he's hanging the limb below. So there is
Blood circulation will
dependent,
increase. It will give more
yeah,
circulation.
better extraction of oxygen will take place. That will help for the pain relief.
Okay. What are the causes of night pain in a patient of peripheral vascular disease? Audience, Tanishka, whoever can answer. Why patients have night pain in a case of PVD, vascular claudication? Why night pain? Similar logic on what we discussed right now. That is why I asked the question. The pain will reduce when the legs are dangling from the side of the bed. Due to the gravity, the pain will reduce. So in the night, why will the pain increase?
There is no movement of the leg.
So legs will be
Blood,
supine.
yeah.
So because of less blood flow when as compared to when the
Less
patient is
blood flow.
standing or when the patient is in sitting position, the blood flow increases. But when the patient is supine at night, the blood flow decreases compared to when he's standing or sitting. So less blood flow, that is one cause of increased pain. What else? There are 3 causes.
Calf muscles, because they are not they are relaxed in the night.
So what will that do? That is, are you talking about the calf pump for soleus and popliteus pump? Then it's of no relation over here. That is for the venous system.
For the negative pressure,
There's no negative pressure. See, in the shall I tell the answer? Anyone else wants to attempt? So the causes of night pain in a patient of peripheral vascular disease are when the patient is supine, so the blood circulation decreases as compared to when he is in standing, which I already said. That is the first point. The second point is because the normal sympathetic tone when the patient is working or active is higher and the patient is sleeping, the sympathetic tone decreases. Okay, so when the sympathetic tone slightly decreases, the blood circulation to the lower limbs decreases. because of the tone is less, so there is vasodilatation everywhere. So blood will not, enough blood is not reached. That is second cause. And the third cause is when the patient is lying, there is convection, heat convection from the bed to the patient's body, and the patient's body temperature slightly increases. So again, that causes vasodilatation, which causes inadequate blood flow to the legs. That those three are the contributing factors for night pain. Okay, so that is decubitus. What is posture? Difference between posture and decubitus? Very important and conceptual question, and many examiners like to ask this question.
Posture is how a body, like it's not specifically whether we are standing or in supine position. Whereas decubitus is only when we are in a lying position.
Okay, you're on the correct path. Not exactly, but going there. So posture is a part of the body with respect to the other parts of the body. All right, and decubitus is the position of the body in the supine position, in the lying down position. That is the decubitus. Okay. Can you give me some more examples of postures or decubitus which specific types of patients take? What other ideas can you get from the decubitus or posture of the patient? I'll give you examples. Suppose the patient is sitting in the bed with on all his fours and is leaning forwards. Then what do you think of? Pancreatitis. Very good. Because the pain will reduce when the patient is leaning forwards or is on all his fours. Then if the decubitus is, I say the patient is lying in the bed with both his lower limbs externally rotated like this. The foot is externally rotated like this. Then what hint will you get when you see the patient like this? Medicine wise, it will be a medical case, not a surgical case mostly. But if the limbs are externally rotated, normally when a patient is lying supine, the toes are pointing in which direction? Like this or like this? Now the normal person is sleeping when he is awake in a supine position. No, not hip dislocation. Stroke, yeah. So when the tone decreases in hypotonia or in paralysis, the limbs will go like this. That is also decubitus. Paraplegia, correct. Stroke, paraplegia, all those things. Or hemiplegia, one of the limbs will be like this, and one will be like this. Okay. What else? You can start, see these things, you can start making your own notes. When you start reading and when you come to different chapters, you will not find a question where all the decubitus are written in one place, but you have to start making them. So when you start reading pancreatitis, you see some specific posture, make a column of different types of decubitus and write it in that. Similarly, when you that is how you will assimilate all the knowledge together. So proceed. Temperature you said 98 degrees Fahrenheit. Okay. Heart rate. Can you read it? Can you read quickly from the heart rate?
80 beats per minute in radial artery while in sitting position. It was a regular rhythm, adequate volume, moment force, tension, character. No apex pulse deficit.
Okay.
Respiratory rate found to be 15 breaths per minute. Blood pressure was 162 by 107.
Okay. One second. Okay. Yeah. So how did you check the blood pressure? Let's speed it up a little bit. We have a lot to discuss. How did you check for the blood pressure? What instrument did you use to check the blood pressure? Simple question. The instrument used to check the blood pressure is called a
Sphygmometer.
Sphygmomanometer. Okay. So do you have a sphygmomanometer?
Right now?
No. When you examine the patient, did you have a sphygmomanometer?
Yes.
Which one? What type?
It was a digital one
Digital one. All right. Why am I asking this?
because there are some variations while we do from the digital one or the manual one.
Yeah, all that is okay. Why am I asking this? How did I come to know that the sphygmomanometer you used was a digital one and not a routine normal one?
Due to the error,
No, there's no error. The error happens because of the cuff size. There's a whole separate discussion on that. We can discuss the pulse and blood pressure for an hour or so. Yeah, Zeal is correct. The odd number seen in diastolic blood pressure. What are the values when you do a manual BP reading? It will always be an even number. Okay. So even if I don't know what kind of BP instrument sphygmomanometers will be given to you at your exam place, but to assume that it's a manual one, assume you are giving a manual one, and if you fake a reading and if you write an odd number at the end, then the examiner will realize that you have not done it. So better to always keep an even number firstly. If it's allowed or if it's a automatic one was given, then you can always justify that an automatic sphygmomanometer reading is there. Yeah. So from your blood pressure, is it normal?
normal is around, it's higher.
Higher, no? Yeah. Is the pulse pressure normal in your patient?
Pulse pressure. Yeah, it's normal.
Pulse pressure is also high, no?
Should be, pulse pressure should be 60 to 100, right?
Pulse pressure.
Okay, sorry, pulse pressure. Yes, it's
Pulse pressure
higher.
is the difference
Normal
between
should be
pulse pressure is systolic minus diastolic is the
diastolic.
pulse pressure.
Yeah. Yes.
Okay, normal is about around 40 or so, and in your
Yeah,
case it is 60. Okay.
Yes.
So if the systolic pressure is 160, then how are you getting normal force, tension, and all? Won't the force be higher? You are describing a hypertension patient, and you are
Yes.
describing a normal heart rate, a normal pulse measurement. And instead of the heart rate, you should have written pulse over there. That's better because you are examining the whole pulse. No? Yeah. So what is force? What is volume? What is tension? Condition of vessel wall, apex pulse deficit. Quickly. Radioradial delay, radiofemoral delay. What is definition of pulse?
Do I need to explain all the terms?
Yeah, quickly.
So should I start with pulse?
Definition of pulse?
Pulse, it's an arterial palpitation of the cardiac cycle.
One specific word is important which I'm looking for.
Heart rhythm.
No. It's a wave. It's a waveform. It's a flow of wave.
Okay.
Every time the heart contracts, a wave passes through the blood vessel. That is what the pulse is. Okay.
So measurement of heart rate, right? The number of time heart beats 1 minute.
That is the pulse rate. I'm talking what is pulse. Definition of it's a waveform that propagates through the blood vessels because of the contraction of the heart. Okay. What is volume?
How much
Force, volume, tension.
Volume is pumped by the heart in a minute.
When you check the pulse, that blood volume is different. When you check the pulse, with how many fingers would you do it?
3 fingers.
Very good. In what position?
Like with,
Mid prone, mid flexed. Okay? Mid prone. You will not check the pulse like this. The hand has to be mid prone and mid flexed.
yes.
Not in the supine position. That is how you check for the radial pulse. Over here at the end, you should also add all the peripheral pulses I would like to describe in the local examination. Okay?
Peripheral.
All the peripheral pulsations I have examined and I will describe in the local examination. Okay, because it's your cases of PVD, no? So you have to tell all your pulses everywhere. Okay, so add that line over there. So I'll quickly tell you the force volume tension. Okay, what is force? Force is the amount of pressure that you have to exert on the proximal finger so that it obliterates the pulse completely, and it will denote the systolic blood pressure. Force, systolic blood pressure. Volume,
Tension.
volume is for the pulse pressure. How much is the upthrust seen? That is the volume. If the pulse pressure is high, the volume you will feel is more. And tension is how much of pressure, diastolic blood pressure, correct. How much of pressure you will have to exert to feel the pulse. If the diastolic blood pressure is low, you will not need much pressure to just feel the pulse. Okay, that is force volume tension. Character, again a whole different discussion altogether, but it will be going more towards medicine, so we'll skip that. Ulcus parvus, tardas, anacroticus, diacroticus, bisperiens, all that you have to know. Pulsus paradoxus, okay? That is from the medicine, but you should know all that. Apex pulse deficit, radioidal delay, difference between the two pulses, whether it's coming at the same time or at different times. Radiofemoral delay, all that. Why is all this important? Is radiofemoral delay important in our case? In a case of PVD, what will it show?
Radial femoral delay.
Radiofemoral delay or radial delay. If it's present, then what will it signify? Audience?
Some kind of a blockage.
Yes, correct. Okay, heart rate, blood pressure, you said. Saturation, you said 89%. Is that normal?
Yes. Saturation.
Saturation of 89% is not normal.
It should be 90, right? The range 90 till 90% strong.
Yeah, 95 to 100 usually.
95 to 100. Yes, it's lower than.
So 89 is not normal. The patient, then in that case, the patient should be having supplemental oxygen, which should have told in the general examination. If the patient has oxygen, then you will describe, no? With patient has central line in situ, Jalco in situ, with dressings present, all that you have to describe. Okay. JVP, no neck veins, no neck veins seen. Neck veins are not distended, you can see. Normally, it will be present if the patient is sitting, neck veins will be visible. Then you said pallor icterus cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. All right, that's okay. Patient does not have any clubbing. The patient is smoking since so many years. Patient should have developed clubbing, no?
Yeah.
Did you check? Keep in mind, all this has to correlate. All right. Keep in mind. Next slide. Okay. Inspection you have done in supine position. Opposite limb is normal. That is a very important one. Firstly, you should describe the opposite limb. That is correct. Start quickly.
Okay, we identified in the affected limb that there was a dry gangrene affecting his left little toe and the left lateral malleolus with a clear line of demarcation. The nails were brittle. The skin is dry without hair. Ichthyosis were present but below the knee.
All this here, these are the signs of cutaneous signs of ischemia, peripheral ischemia. What you have
Yes.
what else apart from these things? Brittle nails, dry skin, loss of hair, ichthyosis,
Yeah.
gangrenous
Dilated.
changes, and
Yeah.
what else? Loss of
Dilated intradermal vessels, round black compliances on the nails, and there were
one
no.
more palpatory finding, temperature, cold skin.
Yeah, cold skin.
Okay, all these 5-6 points should come in the signs of ischemia. Then Burgess test is positive. At what angle? How did you do the test?
Gorgeous. At 30 degrees, the patient knee was.
How did you do the test? Can you describe the test? Whatever you did.
I didn't do the test.
Didn't do. Okay. So can you describe theoretically what is Burgess test? Burgess angle, Burgess test, Burgess exercise.
Burgess
Difference between
angle
the
is
three. Burgess angle is
30 degrees. Burgess angle.
there is no correct answer. Whatever you say is the Burgess angle. Whatever you saw on your patient will be the Burgess angle for your patient. There is no fake answer कि 30 degree है. Normally, when if a patient is lying supine, normal person, and if you elevate the limbs, keeping the knee straight, extended, even if you take it up to 90 degrees, patient will still not develop pallor of the skin. Patient will not develop pain. The circulation will still be present even at 90 degrees. But in patients with peripheral vascular disease, the circulation is compromised. So even if you elevate the limbs, and if you have to wait for 2 minutes. Okay. So when the patient is supine, then you tell the patient, what will you how will you start? You will start by 30 degrees. First lift the limbs, both the limbs together for by 30 degrees, not actively, passively. You will have to support the limbs. Okay? It's not an active exercise for testing power. So you will not say khud se karo. This is other patients will not be able to do it. Okay? It requires a lot of this muscular this thing. Your abs, rectus abdominis muscles and all have to be quite good. So patient will not be able to do that for more than 10-20 seconds also at a stretch. Okay. So you will have to passively lift his limbs, both the lower limbs together, and suppose you keep at 30 degrees first, then you wait for 2 minutes. If the pallor appears or patient gets pain, then that is Burgess angle and your Burgess test is positive. Suppose the patient is comfortable even at 30 degrees, then you elevate it to 45 degrees, then you do 60 degrees, and then you do 90 degrees. If everything is normal, then you say the Burgess test is negative. Okay. So whatever you got in your thing, you will have to tell. So that is Burgess test is positive. Then soon after you do the Burgess test, you have to do venous filling time. Okay. So you after the Burgess test, you tell the patient to sit and keep the legs dangling on the side of the bed, and you have to see how much time does it take for the redness to come back.
Come back.
Yeah. That is the venous filling time, whether it is delayed or normal.
Yes.
After that, you look for dilated, reddened, and painful superficial veins. So you are looking for superficial thrombophlebitis. Okay.
Yes.
On which part, where will you check for superficial thrombophlebitis? Along the course of, usually along the course of. To check for thrombophlebitis, you will have to know the anatomy of what thing, what structure. You will have to audience which veins, which is the main vein of the lower limb.
Femoral.
GSV. Femoral vein is a deep vein. You are talking about superficial thrombophlebitis.
Superficial vein. Okay.
So which are the two main superficial veins? Greater saphenous vein and lesser saphenous vein. Short saphenous vein. Okay.
Yes.
So can you tell me the anatomy of the greater saphenous vein? There has to be a. This is the foot. This is my leg. This is my foot. Okay. This is the dorsal venous arch which is there on the foot. Okay. Then on the medial side, the great saphenous vein will be formed, and on the lateral side, the short saphenous vein is formed. Okay. It goes anterior to the medial malleolus. Okay. Can you check your medial malleolus? You will see the greater saphenous vein just anterior to it. If you can, if you are a athletic person or a thin built person, you will be able to see your greater saphenous vein right now also. Then it ascends anterior is very important. Anterior to the medial malleolus. Then it extends along the medial side of the leg. Then it slightly goes below posteriorly, and it again comes back anteriorly inside the thigh, and then it travels in the superficial compartment only, and then it at the cribriform fascia, it joins the femoral vein and drains into the common femoral vein. That is at the greater saphenous opening, which is about 2.5 centimeters, which is about 4 centimeters below and lateral to the pubic tubercle. Got it? That is the anatomy of greater saphenous vein. You have to palpate and see either pain ho raha hai kya. You have to see if there is any cord-like sensation. All these are signs of superficial thrombophlebitis. You will not see anywhere. No? You have to see at this point. Similarly, at the short saphenous vein. So start from the dorsal venous arch, then go to the short saphenous vein will go behind the lateral malleolus. Then it will go up and it will enter at the popliteal fossa, and it will go deep over there at that point. And there is a variable exit of the short saphenous vein. जैसा great saphenous vein का opening is fixed, no, at the GSV junction, so at the saphenofemoral junction, SFJ junction, but the short saphenopopliteal junction, SPJ, is not fixed in most of the patients. SFJ is fixed. HSI is 4 centimeters below and medial. Got it? That is how we will look for superficial thrombophlebitis. Then you look for muscle wasting. In the inspectory thing, you will just see thickness of the girth of the limbs. Then
Yes.
inguinal swelling. What do you want to look for inguinal swelling? What are you looking for? You're looking for lymphadenopathy. Very good. Correct. Yeah. So, okay. You missed the venous filling time in this. And
Yes. I think
for you can yeah, inspectory findings are okay. Come, go to the palpation. Yeah, start.
was local decrease in temperature, bilateral lower limb.
How did you check for
increased-
temperature?
in
How
the
did you
lower
check for
limb.
How did you check? How? Options do?
But yes,
Okay. Digital thermometer, infrared thermometer, or hand?
hand. By the
Hand.
dorsal.
What part of hand? Dorsal motor. Very good. With the gloves or without the gloves? In COVID
with
times?
the glove. With the glove.
With the gloves.
Without.
But in COVID pandemic, will you do without gloves?
I will sanitize it after.
Yeah. You cannot check temperature with the
With the
gloves.
glove.
You have to remove your gloves. Okay. So without gloves at the dorsum of the hand. Where will you start? Proximal to distal or distal to proximal?
Distal to the proximal.
Very good. So you found decrease in temperature in both the lower limbs,
No, only the affected one.
but you wrote in bilateral lower limbs.
Should write bilateral left lower limb.
What?
I should be mentioning the bilateral left lower limb.
Bilateral left lower limb. You mean to say the temperature is less in the left limb?
No bilateral, the left lower limb.
Okay, yeah. All right. So that's a correction. Okay.
Yeah.
So the temperature is decrease in the left limb. At what point also you have to say, whether in the foot or in the leg or in the thigh? Because the decrease in the temperature will only be up to a certain point from wherever the block is, wherever the thrombus or the embolus is. उसके
Yes.
distally ही only the temperature will be lesser. Okay.
Below the knee level, right?
I don't know. It will be your patient, so you will have to tell me.
Yes, it will be below knee level.
Below knee. Okay. So if you are saying below the knee and there is signs of ischemia up to the knee also we saw in the inspection. So somewhere the block will be in the lower part of the femoral artery or in the popliteal artery. Okay. Otherwise the signs of ischemia will not come in the legs.
Yes.
Okay. So you started in the foot, and most important thing is if there is bilateral loss of decrease in temperature, then you cannot comment only, because decrease in temperature, how will you compare? You have to compare with the normal limb. Okay. If both the temperature is decreased, then there is some other cause. Patient is hypovolemic or something else. Cold, clammy skin, septic shock, whatever. So in the foot and in the leg, and it is normal in the knee, above the knee. That is how you will say temperature. Okay. What about when you start palpation, two words should come together, one after the other. Which is the second thing that should come? Temperature and then always tenderness.
Tenderness.
Why do you check for tenderness in the second point only? Before doing any test, why do we just check for tenderness first? It is a sign of inflammation, yeah, but like इसमें कुछ there is no super logic over here. It's very simple. No? Why will you check for tenderness? If you know that patient को pain हो रहा है, then will you go ahead with all the tests, or you will modify accordingly, or you will, you know, if he has pain, then many tests we cannot do. We cannot give the patient pain and do all the tests, no? So you have to check for tenderness first. Okay, whether is there any pain, tenderness.
Pain or not.
Yeah. So second thing is always temperature and then tenderness first. before doing any other thing in all the examinations of the swelling of the limb, anything that you do, no local rise of temperature and no tenderness. Okay. Some people use the word there is no warmth. Okay. Over there. That is wrong. You should also only say no local rise in temperature, no local decrease in temperature, or no increased warmth or no decreased warmth. When you say there is no warmth, it means patient is dead. Okay. So what words that you have used are is preferred. Then increased capillary refill time in bilateral lower limbs. How much did you say during the presentation? You said 0.2 seconds, right?
Yeah, it was more than 0.2 seconds.
0.2 or 2 seconds?
0.2 seconds.
Can you show your capillaries? Can you show
Hello?
me your capillary on the camera? Can you see? I'm doing capillary refill time over here. Okay. Okay, it has become pale. Start counting and look at my refill time. Okay. How much was it? Audience? Yeah. What is the normal capillary refill time? 0.2, 2 seconds. That is the answer. Okay. Some say 2 seconds, some say 3 seconds. Different books have given different things, and none of them is, both are accepted. So 2 to 3 seconds you can say. That is the best thing. Okay. So patient has increased capillary refill time. So refill time, it took more than 3 seconds. That is abnormal capillary refill time. Okay. That is a sign for peripheral. This. Next, then you check for pulses. Okay. Bilateral dorsalis pedis is absent, anterior tibial, posterior tibial, popliteal pulses. How much time do we have left? Is everyone tired? Do you want to discuss all the pulses? Do you want to discuss all the pulses or you'll read? Tanishka, you want to say or you? Nethra, should we do the pulses or you want to skip it?
It's up to you. I mean, we could go over it
If
briefly.
people are tired, if people don't want, might not pay attention, then we can skip it.
But this is an important part
It
of
is important,
PVD.
definitely
So
important. It's a long
you
case. PVD is
can,
important case and aega hi. So you want to discuss?
if you could just briefly
Yeah.
go over which
Quickly.
locations to check at.
Take it.
That is the main thing,
Okay.
I think.
Okay. Yeah. So we'll start with the pulses. Okay. Upper limb and then lower limb. Quickly. First, you will tell me the which artery that you checked. Where did you check? Any special position of the part of the body and against which bone? Okay. 4 points you have to say for every pulse. Okay. Can you begin, Tanishka?
Yes.
I checked for Bolo. I checked for the dorsalis pedis artery
Yes.
in the
Okay.
intertarsals, in the first intertarsal space. After extending the extensor hallucis longus tendon, just lateral to it, against which bone? Against the navicular or the cuneiform
Navicular.
or the
Yes.
cuneiform bone. Next is the anterior tibial artery. How did you check? Important point. What if both my dorsalis pedis arteries are absent in me? Then do I have PVD? In me, both my dorsalis pedis arteries are absent, but anterior tibial is present and popliteal and everything is present. So do I have PVD? Audience? Yeah, it's a branch. It's a continuation rather than a branch. It's a continuation. Anterior tibial continues as a dorsalis pedis, but in me it is absent. Then does it mean I'm smoking too much?
We can check for the tibial pulsations first.
So I am saying my anterior tibial is present, posterior tibial is present, but my dorsalis pedis pulsations are absent. Does that mean I'm going to get gangrene of the toes?
No.
Why? मेरा पल्स नहीं है ना, एब्सेंट है तो
It would be
मुझे
the
गैंग्रीन होने वाला
dorsalis.
है.
Only the dorsalis because it's not.
May signify low blood pressure below 90. Not exactly Arundhati. What else? think? You are not able to feel the pulse. What can the cause be?
Might we have pressed our fingers very firmly so that we,
क्या क्या?
it might possible that we have pressed our fingers firmly on a bony surface. That is why we cannot feel the pulsation.
ठीक है. Even if I'm taking up Doppler, ठीक है, ultrasound, and you can see, but still you're not getting dorsalis pedis pulsations. Still, even if you discount any errors in the clinical examination, but my pulsations are absent on the ultrasound also, on Doppler also, in the dorsalis pedis. Then, Bolu, dorsalis pedis arteries can be absent in 15% of the normal population. It is given in BDC also. Okay? So if in a patient both the dorsalis pedis are absent, or if you don't get, 15% is quite a big number. Okay? So you might not get in 1 or 2%. But if one side is there and other side is not there, then it is abnormal definitely. Okay? And especially if other arteries are also not there, then definitely it's significant. Okay? So bilateral dorsalis pedis you said, then bilateral anterior tibial, posterior tibial both and popliteal. Okay?
Interior.
Yeah. So we finished dorsalis pedis artery, right? Against the navicular and the cuneiform bone first. Second is anterior tibial. I check for pulsations of anterior tibial artery where
The midway of medial malleolus,
the lateral malleolus,
lateral malleolus, Achilles tendon.
against the tibia,
Okay.
tibial bone. Okay.
Yes.
Then you check for posterior tibial. I check for posterior tibial artery at the midpoint between posterior border of the medial malleolus and the tendo-Achilles tendon, Achilles tendon at the midpoint. How is the foot be? Internally rotated, so as to relax the flexor retinaculum over there. With the foot internally rotated or inverted at the midpoint between the medial malleolus and the tendo-Achilles for the posterior tibial artery against the which bone? Calcaneum bone.
Calcaneum.
Okay. So dorsalis pedis ATA PTA. Then you come to popliteal. Popliteal pulses. Popliteal artery is palpated against. I have palpated the popliteal artery in which position? Supine or prone? Which is the right answer?
Supine position.
Which is the right answer, audience? Supine or prone? Supine, supine. Both are right. You can do any one or you can do both. Okay. So in supine position, if I check, then it is against which bone? At 135 degrees flexion. Okay. Supine you cannot keep it straight. You will not be able to palpate the arteries. So you have to keep it flexed at 135 degrees. That is how my knee will be. Yeah. Okay. Then here I will check for the popliteal artery against which bone? In the supine position, it will be against ये मेरा tibia है. ठीक है. So against the tibia over here. And if it's prone position against the femur.
Femur.
Supine position against the tibia. Prone position against the femur.
Femur.
Okay. That is the popliteal artery. Then the femoral artery, common femoral. Bolo jaldi. Against the at. I'll check for the common femoral artery at
Inguinal, mid-inguinal point.
Which is the midpoint between ASIS and
Superior iliac spine.
And
pubic tubercle.
Pubic symphysis, no?
Symphysis, yes. Pubic symphysis.
Mid-inguinal point is symphysis. Okay? That is the femoral artery. Then upper limbs, quickly. First here, this is which artery? In front of the tragus, against the temporal bone, superficial temporal artery. Palpated for the superficial temporal artery, in front of the tragus, against the temporal bone. That is over here. Okay? You can feel it. Then over here, facial artery. Very good. How will you check? This is masseter muscle. Well, when you tell the patient to clench the teeth tightly, so masseter will contract. masseter contract, उसके anterior border पे you will feel the facial artery against the mandible, against the body of the mandible. ठीक है, repeat करो फटाफट, you will memorize it. बोल.
Facial muscle against the temporal.
At the anterior border of the temporalis against the body of the mandible.
Anterior border of temporalis against the
Facial artery at the anterior border of masseter muscle against the body of the mandible.
facial artery against the masseter
Mandible.
muscles on against the mandible masseter muscle on the body.
Facial artery के आगे एक मसल होता है इधर, masseter muscle.
Masseter muscle.
उसके anterior border पे the artery is there. So first you have to know now at what point. So you will tell the patient to close this mouth tightly. Then you will feel the muscle over here, masseter muscle. ठीक है, feel the muscle. ठीक है, and then उसके anterior border पे you will get the pulsations. You will feel it against the body of the mandible. ठीक है, temporalis, superficial temporal artery, just in front of the trachea against the temporal bone.
Temporal bone.
ठीक है, two things done. Next कौन सा आर्टरी आएगा?
Brachial artery.
Which carotid? Common carotid. Okay. Common carotid artery was palpated. How? Using how many fingers? Two. See?
Thumb. Using thumb.
Very good. Using the thumb. I was distracting you. Using the thumb. After doing what? Directly you will go and palpate the carotid? Fail कर देंगे तुझे. After, turn neck to the opposite side. Opposite side?
Opposite side. Like opposite of the affected part.
Turning neck is not that important. What is more important is, before palpating the carotid, anyone's carotid, firstly you will not do two carotids at the same time. Most important thing. Carotid में ध्यान रखना है 2-3 चीज. Don't palpate both the carotids at the same time because it will compromise the cerebral circulation. First thing. Second thing, asking the patient to sit. No, that is also okay. Anyhow, you can do it. But the most important thing is take the stethoscope. उसका जो bell है, keep it over here. And what will you look for? Carotid bruit. Very good. Carotid bruit will signify is there any stenosis of the carotid artery. If there is stenosis, then you will not palpate for the carotid. Why? Because if there is any stenosis or there is any embolus or plaque, when you palpate it will dislodge and it will give the patient stroke on the spot. Okay? So in that case, if the bruit is present, bruit will be like a swishing sound, something like that. So if the bruit is there, then don't palpate the carotids. So common carotid artery is palpated in the carotid triangle. Carotid triangle is a part of the anterior triangle of the neck. Okay? So in the carotid triangle, at the lateral border of the sternocleidomastoid, what is it?
Recoil.
Anterior, medial to the sternocleidomastoid, against which tubercle? Against common carotid artery is palpated against tubercle of the C6th cervical vertebra, which is also called tubercle of carotid tubercle, also called tubercle of, very commonly asked question, carotid artery. Audience, tubercle of C6 is called tubercle of the transverse process of 6th cervical vertebra is called that wasn't me. What was it called? Shazag, yeah, correct. Shazag tubercle. Devanshu and Zeel. Okay. This is called Shazag tubercle, which is on the 6th cervical vertebra. So I palpated for the common carotid artery at the 6th cervical vertebra in the sitting position, whatever, after ruling out any bruit with one thumb and only on one side, not two sides bilaterally at the same time, not together. Okay. Spelling ka zarurat nahi, Shazag you just have to say Shazag tubercle. Okay. That is common carotid. Then internal carotid you don't need to do separately. External carotid you cannot palpate normally. You can only palpate it in the bed of the tonsillar fossa, which we don't do. Okay? That is external carotid artery, which is not given anywhere. Then what else? Then you come to subclavian. How we will check for subclavian? Is palpated against the is palpated in the supraclavicular fossa. What special position? After telling the patient to shrug the shoulders so that the fascia over here is relaxed. So cervical subclavian artery is palpated in the supraclavicular fossa after telling the patient to shrug the shoulders and palpated against the first rib at the midpoint of the clavicle. Okay, against the first rib. That is this. Now the two things are very easy. Brachial artery. Brachial artery is palpated, bull.
Yeah.
Not in the cuboidal fossa. Exactly, nahi. Is palpated where?
Elbow.
Elbow, but
Anterior aspect of the elbow.
on against the dash of the humerus. Against the medial epicondyle of the humerus.
Medial epicondyle
of the humerus. And what is the anatomy? Mnemonic tha BDC mein over here. 4 structures that pass from here. Not MBBS. I don't know. My mnemonic was something different. One is M, that is median nerve. Then second is biceps. Then no, second is brachial artery. That is BB में वही confusion होता है. Then median nerve, brachial artery, tendon of biceps, and the last is the radial nerve. MBT. My mnemonic was मेरे बाद तेरा roll number. ठीक है? My M मेरे बाद. M is median nerve.
Median nerve.
Median nerve.
Median nerve.
Median DIAN median nerve.
Median.
Median nerve. Then B is बाद. बाद में there is brachial artery.
Brachial artery.
Then तेरा T is for the tendon. Okay. Tendon of the biceps muscle.
Biceps.
And then R is the
Radial nerve.
Radial nerve. Okay. So how will you check for the brachial artery? You will tell the patient to contract his limbs, contract his hand, aisa, and you will give resistance. When you give the resistance, what will become prominent? The tendon of the biceps muscle will become prominent, and you will be able to feel it. You will be able to feel the tendon of the biceps muscle, and just put your hands medial to it, so you will get the brachial artery. I don't know if it's visible here. Okay. That is the first you will have to identify the biceps tendon, then go medial to that, you will get the brachial artery against the medial epicondyle of the humerus. Keep repeating quickly, ये बहुत ही important है. चल next, radial artery, ulnar artery is palpated with the hand kept mid prone, mid flexed. Radial artery is palpated against the radius bone, and ulnar artery is palpated against the ulnar. Okay. If you want to palpate the radial artery in the in the anatomical snuff box, then you will palpate it against scaphoid bone. This is the anatomical snuff box, remember?
Yes.
That you palpate against scaphoid, but over here you palpate against the radius. Okay? Okay. Then what proceed to continue with the palpation?
Axillary.
Any doubt in up till now in the pulsations? Any procedure, any method you want to ask? Any specific?
I think there was a doubt that came up earlier. That is, can you repeat the difference between absolute and functional distance?
So suppose I am starting to walk and 500 meters ho gaya, and now I have started getting pain. Okay, but I still continue to walk with pain. And then at 800 meters, I'll say, nahi, abhi bahut pain ho gaya, I will never be able to walk after this. So the absolute distance is 800 meters, but the functional claudication distance is 500 meters. It's not very important. Not many people will ask about this as compared to what I just told you about the pulsations. Understood? That is the difference between functional and absolute claudication distance. Okay. Can you continue with palpation then after the pulsations are done?
Should I move to next slide?
Continue with palpation. At peripheral pulses you done, then tender veins are present. What does it signify?
Then, like the pain is present.
So that signifies superficial thrombophlebitis, right?
Yes.
So you are pointing towards Burgess disease,
Okay.
because Burgess disease में क्या होता है? Superficial thrombophlebitis is there, no? One of the things. Next, no sensation loss except in the area of gangrene. Okay. How did you check for sensation? It's 1 o'clock.
Like you can. For
Sensation is checked with, touch sensation is checked with a cotton wisp.
cotton wisp.
Okay? You take a
Cotton.
piece of cotton wisp, you show him, see, this is how it will feel. Make him touch on the hands, and then you tell him to close the eyes, and then ask them, feel हो रहा है कि नहीं? Okay?
Yes.
How in what areas will you check up to the as per जहाँ मान होगा where there we will check. You have to check as per dermatome level. ठीक है? L1, L2, L3. There's a diagram of the dermatomes, no, in the anatomy textbooks. As per that you have to check. L1 के कोई भी dermatome में check करो, L2 का dermatome, L3, and so on. ठीक है? Then for what is the type of sensation loss in diabetic neuropathy?
Like in diabetic neuropathy.
In a case of diabetic neuropathy, very good, very good. Z. The answer is on a scale. What is the type of sensation loss?
Stocking.
Glove and stocking type. And how is the type of pain? Patient will prescribe as dash sensation.
Dye sensation.
What sensation?
Dye sensation.
Dash type of sensation. Fill in the blanks.
Dye.
Diabetic neuropathy pain will be dash type of pain. Pins and needle sensation in the glove and stocking type. Glove and stocking मतलब क्या? In the hands and in the foot.
Foot.
ठीक है? And pins and needles, like patient बोलेगा needles जैसा pain हो रहा है. ऐसा लग रहा है someone is pricking me with lots of needles. That is the type of pain in diabetic neuropathy. Why is it in the gloves and stocking type? ऐसा क्यों है? Because of microangiopathy. Microangiopathy begins in the distal vessels, retina, kidneys, glomerulonephritis, ophthalmic conditions जो भी है वैसा, hypertensive retinopathy, diabetic retinopathy, all these are microangiopathies. Diabetic पे पूरा अलग वाइवा जाएगा, ठीक है? Let's not go there. Then you went to inguinal lymph nodes are not palpable, ठीक है? You did not. If there is a gangrene, then you should also check for movements of the proximal joints. You should also describe the gangrenous part in detail. ठीक है? Proceed. Yeah, percussion auscultation not going to be okay. Systemic examination. You missed that, no?
What?
Systemic examination. Systemic. CVS, RS, for abdomen. You should just say 3 words. CVS, S1, S2 present, no murmurs. RS, air entry bilaterally equal, no adventitious breath sounds. For abdomen soft, and CNS conscious oriented. All these 4 points of the systemic examination you should say in a long case. Okay? Then you came to the local examination. Okay. Final diagnosis.
Left lower limb.
Left lower limb.
Yeah. We found
Peripheral artery disease.
Yes. With the accelerated atherosclerosis and a complication of dry gangrene of left lateral malleolus and left fifth toe, small toe.
Okay. All right. No one will be able to tell for sure whether it is atherosclerosis or Burgess disease. But yeah, both options are open to us. So I accept whatever diagnosis you said. How will you investigate the patient further? How will you manage the patient in general? As soon as you say the final diagnosis, the next question will be, what will you do further for this patient? You should also mention the age again in the diagnosis.
A UCG?
And along with diabetes and hypertension, if the patient has, you should also mention that. In a known case of my patient is a 65-year-old patient with left lower limb peripheral artery disease, mostly atherosclerotic thrombosis, most likely in the popliteal artery or in the femoral artery, with complication of dry gangrene. In a known case of diabetes, hypertension, whatever. Okay. How will you proceed with the patient?
We will ask for the USG.
I will.
I will ask for the USG and color Doppler.
That's called ultrasound plus Doppler examination is also called what examination? Dash scan. Ultrasound plus Doppler is called duplex scan. Duplex scan. Okay. So I would go ahead with the duplex scan for this patient. That is in the imaging. Any blood investigation would you like to do?
We didn't do any blood investigation.
Okay. What is ABPI?
ABPI was found to be around.
What is ABPI? Very good, very good. Okay, okay.
Arterial brachial pressure index.
What is the definition? What is the form?
The systolic pressure is compared to the brachial artery pressure.
Systolic. What is the full form firstly? ABPI ka?
Ankle brachial pressure index.
What is the formula?
Formula is
Systolic blood pressure in the ankle divided by systolic blood pressure in the brachial artery. Okay. In the ankle, you will take the anterior tibial artery. Okay. So that pressure you would divide both of them. Okay. So how did you measure the systolic blood pressure in the brachial artery? You already have it, no? Systolic blood pressure of the brachial artery.
Pressure, yes.
160 you got.
162 okay. By 107. 162.
You got the systolic pressure is 162.
Yes.
Okay.
Yes.
How did you take the systolic blood pressure in the ankle?
We can I will ask the patient to plantar flex his knee, and from the two fingers I will the middle part of the malleolus.
You will keep the stethoscope over there.
Yes, I will keep the stethoscope over there.
Okay, and will you use the same cuff? Upper limb का जो cuff आता है for brachial artery, will you use the same thing? No, na, it will be different, na. You have to check for a different part of the body, no? So there has to be a special cuff for the legs. Okay, only then you can do, no. You have to properly obliterate that artery, and then you have to look for the systolic heart sounds, systolic sounds, lub dub dub whatever. Okay, but suppose you don't have the cuff. Do you have it? Did you have it when you did the ABPI? What?
I do not remember.
Achha, see. So I'll tell you how to do ABPI. You do the systolic blood pressure. We normally take the blood pressure. Okay, of the brachial artery that you got. Okay. Now you want to take the systolic blood pressure of the ankle of the anterior tibial artery. Okay. So what will you do? You will take the cuff and obliterate the arteries after tying it in the cuff, in the legs. Then what you can do is, instead of taking a stethoscope, have you done gynec postings, obs postings?
No, I am just in the fourth year right now.
Okay. Yeah. So see, have you heard of a hand Doppler? Gynec patient.
Yes,
gynec,
I have heard of hand Doppler.
They use it to hear the heart sounds.
Yes.
ऐसा रहता है. You can use that and keep it. And if you again do the obliteration of the pulses using the sigma manometer, then when you start decreasing the pressure, what will you see again over there? You will hear sounds. Dub, 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 dub on the. Have you heard from that speaker? They hear it. It will give sounds. So the handheld Doppler will give you some sound. There's a speaker in that. So as soon as you reach the systolic pressure, you will get the sounds. That is how you will get the systolic blood pressure at the ankle. Okay? And your systolic blood pressure was 0.7. So what does it signify? Mild, moderate, severe, critical. What is normal?
Normal.
We'll continue for 10-15 more minutes. Huh? What is normal ABPI? How much is the normal ABPI?
0.7 to 0.9. Sorry, more than 0.9 is a normal.
Okay. See, different books are giving different values, but just understand it has to be around 1. Okay? Everywhere the values are changing, but just you have to ankle pressure is slightly more than the brachial pressure. So normally it has to be around 1.1 or 1.2. Even up to 0.9 is okay. Okay? That is normal ABPI. Then there is a grading: mild, moderate, severe ischemia. So it will be like 0.7 to 0.9 or 0.4 to 0.7 and less than 0.4, all that. What is
Yes.
critical limb ischemia definition as per ABPI? ABPI of less than
0.3.
3 is critical
Okay.
limb ischemia.
Yes.
Okay. What if I told you that the ABPI of a patient who is a diabetic 65-year-old male is 1.5?
1.5.
So it's very good.
Yes.
Very good. More, even better than normal.
Better.
Okay, you can ask him to do an ABPI again after exercise, but it's still high only. It's even better, or it's normal. Very good, very good. It is because of the calcifications.
Yes. Yes.
If the arteries get calcified, so your ankle pressure will be high. When you, even if you try to obliterate, वो obliterate नहीं होगा ना artery. ठीक है? So you will have to put a higher pressure to obliterate that artery. So your systolic blood pressure will get is high because of the calcification. And that is why the ABPI for such, even if the patient has critical limb ischemia, his ABPI will be 1.4. But the patient has critical limb ischemia, पूरा gangrene हो गया है, गंदा हो गया है foot. But still the ABPI is normal. So what will you comment on ABPI in this case? ABPI is not always foolproof. Okay?
Okay.
So in calcified vessels in a diabetic patient, ABPI is abnormally high.
High.
Abnormally normal. You will give a falsely normal value. Okay? So in that case, what will you do? In a diabetic patient or in calcifications, what will you do? We can take TBPI.
Doctor,
What is TBPI? Audience, TBPI. Similar to ABPI, we can do toe brachial pressure index. Okay?
Okay.
For calcified arteries due to diabetes, we can do TBPI. Otherwise, Doppler is always there. Okay, so what else will you see in Doppler examination? Duplex scan. Doppler will only give you colors, okay? And ultrasound is needed for the anatomy. So if you want to do both together, you have to say a duplex scan. And you have correctly mentioned arterial duplex. Because venous scan bhi hota hai. You don't need a venous duplex scan. Okay, we will ask for because the cost will also increase if you say lower limb bilateral, lower limb duplex scan of the artery plus veins. So it will be a lot of things. We only need arteries, you know? So arterial duplex scan. Okay. What will you see? What else will you see? You can see the site of the block.
Site.
You will get the ABPI. You will get the blood flow. You will get the waveforms. Have you heard of the waveforms on Doppler examination? Normal blood flow. Have you seen any Doppler report?
Yes,
I'll tell you. I'll read you a Doppler report. Okay. Yeah. See, someone is telling. The waveform is triphasic in the femoral and the popliteal artery, and there is biphasic waveform seen in the ATA, PTA, and DP. Anterior tibial, posterior tibial, and dorsalis PD is biphasic or monophasic waveform is seen, and in the femoral artery, triphasic waveform is seen. So what does that mean?
Triphasic is a normal.
Normal.
Yeah.
And
Biphasic and monophasic are abnormal.
correct. So how is this phasicity seen? If you see when you're doing a Doppler scan, no, on the screen you will see phases. You will see a graph on the screen. There is a systolic phase, then there's a diastolic phase, and there is again a systolic runoff. Three waveforms are seen. One will go above the line, one will go below the line, and then another smaller peak is seen. That is triphasic waveform, which is normal. Okay. The third waveform that we see, no, that systolic waveform. Yeah, that means the case in that case block is somewhere in the popliteal region. You are correct. Z. Yeah. So the third systolic peak that you see, no, is because of the backward reflections of the arteries. It's very difficult to understand. Even frankly speaking, even I don't understand it properly. But what I have read is, whenever the pulse goes, the waveform goes like this. There is a reflection of the waveform which comes again in the opposite direction in the vessels. Okay, waveform of the heart contraction ka waveform travels like this, and then the reflection of the waveform comes back in the opposite direction. After reaching till the end, it comes back. Okay, so the third wave that I'm telling you is because of that reflection, which is coming back. Okay, so normally you have to see all the three waveforms: systolic, then the diastolic, and then the third systolic. But when the atherosclerosis and calcification and plaques start forming, the third waveform goes away. Only two waveforms are present. Then when the stenosis becomes more and more, only one waveform is present, which is monophasic waveform. Okay? And then at the end, when complete stenosis is there, all the waveforms are absent. Got it? What other investigation would you like to do?
The MR angiogram, the digital subtraction angiogram.
Digital subtraction angiogram, then CT angiogram. Okay. What will you see in CT angiogram if there is a block? Suppose I say there is a corkscrew appearance around the popliteal artery with a distal runoff, and there is a filling defect of about 4 centimeters in the popliteal region. Then what will that point towards?
The blockage at that
point. Then I said there is a distal runoff, distal to the popliteal artery. It is present. So what does that mean? That means contrast. See, when you do a lower limb angiogram, no, you put a gelco in the gelco, you put an IV line in the upper limb. Okay. Then the contrast goes to the heart and then it goes to the arteries. Okay. And when you do an angiogram of the upper limbs, you have to put a vein flow in the lower limbs, in the foot, so that the contrast goes to the heart and then in the arteries. Itna samjha? So when I say that there is a filling defect in the popliteal region, you know how a CT angio is seen? You will see we make a MIP image where the whole body is seen, photograph, and all the vasculature is seen as white lines. All the arteries become white. Okay. So if there is a block, suppose if I say there is a block in the femoral artery, everything below should be black, no? Up to the femoral it will be white, niche it will become black. Okay. But if I say for some part there is black and then again white comes, which is distal runoff. Runoff matlab kya? Contrast has run away, beach mein black ho gaya, and end mein again it has become white. Are you following?
Yes, yes.
So in that case, what do you understand? And when I say there is no distal runoff, if you please hurry up a bit. Yeah, see, okay, I will finish it up. So if there is no distal runoff, what does it mean? And if there is a distal runoff, what does it mean? I'll tell you. So if there is a distal runoff, means there will be collaterals. This is a chronic case. Collaterals are formed and they have again joined and formed another. They have again formed, and niche ka jo blood vessels hai, anterior tibial, posterior tibial, all those vessels have a good blood supply. So collaterals are present. And if I say there is an embolus or an abrupt cutoff was there, some trauma is there, someone has ligated the artery achanak se, and then you do a angio, then there is a abrupt cutoff and there is no runoff. Matlab in the anterior tibial, posterior tibial, everything will become black. So that means there is an abrupt cutoff. That is the difference between abrupt cutoff and a chronic phenomena like a thrombus, where the collaterals will be there. Why is it important? Because the treatment will change. Suppose there is a filling defect in between, but बहुत सारे collaterals बन गए हैं, and artery, this is there at the end also. Then how will you manage that patient? Suppose your patient is there, and in that case, I say that there is a small defect in the popliteal region. There is good amount of collateral formation, and again, the distal blood vessels are normal. Then how will you treat your patient? Last question: how will you treat? First, lifestyle.
Like, or medicines.
First point, lifestyle. In that lifestyle, what will you tell the patient?
For the to quit smoking.
Quit smoking, diabetic control, hypertensive
Diabetic
control,
control,
exercise.
hypertension. Yes.
Exercise. What will be Burgess exercise? What will you tell him? Burgess exercise mein you tell the patient, okay, you sleep supine, then take your lower limbs, elevate it up to 30-40 seconds. You will feel the pain. And after that, again bring the legs down, just like you do in Burgess test, no? Again bring the legs down. So this thing will again. So what will happen is Burgess exercise will stimulate collateral formation. Okay? Because of which the pain will eventually decrease. And counseling. How will you counsel the patient with intermittent claudication? You have to tell them that the pain is harmless. The pain will happen, but you have to try to continue to walk even with the pain. As you walk, the collaterals will form, and eventually your claudication distance will increase. Along with medications, along with exercise, along with lifestyle control, your claudication distance will again increase after collateral formation. So you have to tell him all these exercises, and you have to counsel the patient that you don't need to worry. Pain is harmless. You can continue to work even after that. Okay, and you have to motivate him. That is the lifestyle changes. What other drugs will you like to give for medical management? If it's hyperlipidemic, then what will you add? Statins. Very good. If there is any high risk of cardiovascular events and all, then we will add aspirin, clopidogrel as per the guidelines. For other, what other drugs do you know of which are used in peripheral vascular disease? Pentoxifylline, which is called Trental. Mechanism of action.
Increase the blood flow.
Pentoxifylline is a rheological agent. I'll tell you the three drugs, okay, which we give together usually. Trental, Complamina, Stilose. Trental is pentoxifylline, Complamina is xanthine nicotinate, and Stilose is silostazole. These three drugs you have to know. Pentoxifylline is a rheological agent. It increases the pliability of the RBCs, so they flow fast. Okay. Second is Complamina, which is xanthine nicotinate. It is a vasodilator. Okay. It is a niacin derivative, and it is a vasodilator. It increases the blood flow to the lower limbs. And the third is the silostazole, which is brand name is called Stilose. It is again a phosphodiesterase 3 inhibitor, which will increase the vasodilatation, and it will decrease platelet aggregation. Understood? These three are the medical management along with statins, aspirin, and all. And surgical management, do you know of any names, procedures?
Balloon dilation.
And
embolectomy, stenting.
Very good, very good. Correct. And finally, अगर open surgery करना है तो that will be called long areas of stenosis are there. Bypass
graft.
That's it. In general, in one word, what is the basic difference between stenting and bypass? For smaller blocks, like 6 to 7 centimeters, 40 centimeters ke blocks. When the blocks are smaller, when the distal arteries are better, we prefer stenting. And when whole long length stenosis is there, and there is no distal runoff, again there is a lot of thing to it. All the length and size you have to find out, but then you will then prefer bypass graft.
Bypass.
Okay. Yeah, that's it. Cool. Great, good presentation.
Thank you, Dr. Parth, for this informative session. If there are any doubts that anybody has, feel free to type them in the chat box, please.
Yeah. If you have any doubts, you can email me later.
Okay, so I will be sharing. Okay, we have a doubt. Sir,
Embolectomy.
can we do an embolectomy?
The embolectomy usually, for that you have to have an embolus. Okay. Embolus is what? There's a sudden blockage. If there's a sudden blockage which is there, suppose in a case of cervical rib or some trauma had happened proximally and an embolus is formed at that point because of tunica intima's damage and an embolus is formed, then you have to do an embolectomy. How is that done? That will be firstly done within 4 to 6 hours to save the limb, especially. So what you have to do is you have to open the vessel, you have to cut it, and then we insert something called as a Fogarty's balloon. It's like a Foley's balloon only. Have you seen a Foley's catheter? Yeah. So a Fogarty's balloon is similar, which is longer, and the balloon, there are various sizes of balloons available. So you insert the Fogarty's balloon through the veins, through the artery proximally, then you inflate the balloon and you pull it back. That is embolectomy. So you cannot do it in this patient because it's a chronic patient. It's a thrombus. It's not an embolus. Thrombectomy also you can do, but if depending on the various indications and contraindications. Not in this case. Anything else?
So I don't see any more doubts coming. I will share your email with everybody. So in case they have doubts later, they can always contact you. Thank you for your time, and it was great learning from you. And thank you so much. We have another session on 11th September, which will be on breast lump, and that will be a long case discussion as well. So I hope the people who joined us today will join us again next Sunday, and we'll have more participants next Sunday. So thank you so much for your time. If anyone has any more doubts, you all are free to ask them right now, or you all can leave the call.
Thank you, Tanishka, for the presentation. It was a good one. Good efforts.
Yeah, thank you, Tanishka.
Thank you so much for having me as a case presenter. Thank you, sir, for explaining everything so well.
Thank you, everyone. See you next Sunday.
Yeah.